Today, our discussion centers around the funding and treatment of our citizens with behavioral health problems and how this affects our jail population. Moderating our session is Ann Deacon, the Human Service Manager of the Whatcom County Health Department. Ann is licensed as an independent clinical social worker and has over 40 years of experience working in this field of behavioral health. Her past roles include managing the state prison for offenders with mental illness, directing outpatient and residential clinics for mental health and substance abuse disorder, and administering human service programs at a state and a local level. So please make sure your cell phones are turned off, and I will turn this over to Ann, who will set the stage for our talk today and introduce our speakers.
There's some way to climb up over on the other side.
Yes, on the other side.
Oh, it's on the other side. I don't know why. Good afternoon, everyone. Today we're fortunate to have two speakers that will help inform us about current activities underway to prevent and reduce incarceration, as well as help us understand how state healthcare reform efforts may impact these local efforts. Now, this may seem like a bit of a disconnect, but what we do know is that many people who frequently interface with our criminal justice system are challenged with addiction and mental health problems, known as behavioral health disorders. The state's initiative to integrate publicly funded primary health care with behavioral health care will directly influence how services are provided to this population. Now, before I introduce our speakers, let me direct you to some handouts on your table. The first one looks very academic, and it is a document produced by the Washington State Institute for Public Policy. This is a nonpartisan research public service center of the Evergreen State College, and this particular handout provides examples of programs used in correctional facilities as well as the community, providing services to offenders. And the last column of this report shows the percent chance that benefits of each of these particular programs would exceed the costs. And we often, at the health department, reference this document as well as others when we are planning our own local investments and interventions to ensure that we're receiving the optimal results possible. So you will note that some of the community-based programs don't yield a high return. You'll also see my notation that I entered at the top right part that basically states that treatment alone is rarely an effective intervention to reduce criminal thinking and behavior. This is often a misconception, but mental illness and addiction is an equal opportunist, and it can impact people who are law-abiding citizens, and it can also impact people who commit crimes. So, mental illness and addiction needs to be treated, absolutely, but also in order to reduce criminal behavior, we need to address criminogenic risk factors. So the programs that we look at when we're creating criminal justice diversion programs also have to address those criminogenic factors. We're also often asked, what are we doing to prevent incarceration? So we will hear much of that today, but I want to also draw your attention to this green handout, which is a list of all the things we're doing right now, which is a lot. And these are a list of pre-arrest, specialty courts, reentry services, and recovery support services that are designed to reduce and, in part, also prevent incarceration. So, good news is we're doing a lot. The good news is we're going to do more. And so, that leads us to our speakers. We have with us today Jill Bernstein. She is the co-chair of our Incarceration Prevention and Reduction Task Force. She has been a lawyer since 1978, joined the Public Defender's Office in 1982, and remained as a defense lawyer in public and private practice until she retired in 2010. She served as president of the Washington Association of Criminal Defense Lawyers and just received the Pemberton Award from Law Advocates for her lifetime commitment to justice. She is well-deserved. She is a past president of the League of Women Voters of Bellingham and Whatcom County. And our other speaker today is Bob Crittenden, often referred to as Dr. Bob. I guess too many syllables in the last name, that's all I can figure out. So,
How does it spell it?
he serves as the governor's special assistant for health reform implementation. He was on the faculty of the University of Washington Schools of Public Health and Medicine, and a family physician serving urban underserved people. He has worked for the state legislature. He was a Robert Wood Johnson Health Policy Fellow with Senator George Mitchell, was special assistant to the Governor Gardner for health, working on a wide range of issues such as the expansion of Medicaid, the Department of Health, and the 1993 Health Reform Law. He was a principal officer of the Herndon Alliance for 8 years, focusing on communications and coordination in support of passage and implementation of the Affordable Care Act. So, today I will ask Jill to start us off. She's going to give you a brief presentation. We'll have Bob give us some information as well on some of the efforts at a state level. And then I will follow with a few questions, and then we will open it up to all of you for questions. So with that, let us welcome Jill.
Thank you so much. I understand that I have about 15 minutes, and so I'm going to talk briefly about what the Incarceration Reduction and Prevention Task Force has been doing, but I am happy to talk all day long and answer any questions, share emails. It's my passion and my pleasure to talk about it. So I'll just talk briefly today and tell you that it is a really interesting group that's hard at work. For me, as you heard, I was 30 years as a criminal defense attorney. That means I handled criminal cases that were felonies and misdemeanors in county courts, in the municipal courts, up and down the I-5 corridor, and spent a lot of time in jail. I have thought long and hard about crime and criminals and how and why people change and how we use our resources, and I would tell you that personally I am really committed to the notion that we can do better. But today I'm going to speak to you wearing the hat of Jill as the proud co-chair of the task force, where I share responsibilities with Jack Hovenier. And the job that we've been given by the county council is to, and I'm going to read this, continually review Whatcom County's criminal justice and behavioral health programs and make specific recommendations to safely and effectively reduce incarceration of individuals struggling with mental illness and chemical dependency, and minimize jail utilization by pretrial defendants who can safely be released. That's quite a mouthful. And it's quite a group that the county council put together. It's a group of very unlikely individuals seated at the table together. One of the documents you have on your list shows the 24 members of the task force, and you'll see that it includes elected officials, people whose background is criminal justice, folks who know all about behavioral health, people who are leaders in nonprofits in our community, and just people who are concerned citizens. And organizing all of this is very difficult because, in fact, we don't use the same lens, obviously, to view the problems at hand. We don't even share the same language and vocabulary about how we talk about problems or the questions of jails and behavioral health issues. And maybe there's a positive in that as you look at people who know nothing about behavioral health, like myself, you get to look at things with a fresh eye and ask perhaps fresh questions. And then there are people who know nothing about criminal justice, and they get to look at things that have been standard practice, and perhaps they're looking at things with a fresh eye and asking fresh questions. But I would tell you that it's a continuing and difficult effort to make sure that we understand and respect each other's different roles and needs and resources and programs and even future dreams and visions for the community. And also, just looking at the personalities involved, it's a continuing effort and sustained effort to understand that cooperating and collaborating and compromises are positives and not negatives. But with that in mind, we have all rolled up our sleeves, and I would say to you, in all honesty, that I believe that everyone's working towards the goal of reducing and preventing incarceration in Whatcom County. And so we're at work. But there's some things that we're not. We're not asking or answering the question of whether we need a new jail. We're not asking or answering the question of where it should be located or what size it should be. There are other groups that are working on this. The community has created the jail stakeholders working group, I think is their name, and they're looking at how to fund a new jail with an idea that they're going to have a proposal to put on the next ballot to ask you to fund a new jail. And the county council is tasked with looking at size and location for a facility. So there are other groups working on that, and the group that I'm involved in is trying very hard to stay focused on the task at hand, which is reducing and preventing incarceration. The county council has given us a resource through the Vera group. These are people out of New York who have been hired to provide us with technical expertise, and currently they're working with us to help map our current criminal justice system, to look at what we're doing, how we're doing it, to look at what gaps in services we might have, to look at what opportunities for fresh programs might be available to us, and to share with us strategies that are working effectively around the country and things that perhaps we haven't thought of. So we are excited to have the resource of the Vera Group, and they, being from outside of Whatcom County, can perhaps help us to see things that we couldn't, those of us who are intimately involved in process, couldn't see on our own. This is a meeting-intensive process. We have broken into 3 subcommittees, that each of which meets once a month. The group as a whole meets once a month. There's a steering committee that meets once a month, and that means 5 times a month there's something happening with the Incarceration Reduction and Prevention Task Force. All of the meetings are open to the public, and may I encourage you to attend. I think having the public there, having your eyes and ears on the process helps our elected officials to know that our community remains interested and concerned about this process, and truly will hold everyone's feet to the fire. So come and join us. You can find a link for our work on the county's website. Just put into your search engine Whatcom County Incarceration Reduction and Prevention Task Force, or any part of that. And you'll find a calendar and come. And I think it's interesting, and having you there is important. So as I said, we've broken into 3 subcommittees that are working on different parts of the problem, and one committee is focused on a new, improved, enhanced triage facility. This was the first task that was really given to us by the county council. For those of you who don't know, we do currently have a triage facility in our community. It's located out in the Iron Gate area off of Division Street, sharing a location with the jail alternative site. It's a small facility that has 5 beds for mental health, people in mental health crisis, and 8 beds for those who are needing detox from drugs and alcohol. This is a facility that provides short-term services from folks who are in crisis, with the idea of hopefully stabilizing them and helping them to connect then with more long-term services. If you think about it, it's an opportunity for people in crisis not to have to use the emergency room or healthcare services at the hospital, and hopefully to have their behaviors managed in a way that doesn't lead to incarceration at the jail. It's an important facility that is almost always full right now. So bigger will be better, and there are limits to how big we can go. Some of the limits are put to us through funding questions through Medicare. Medicare will only pay for services for facilities that are no bigger than 16 beds. So our vision is for 16 beds to focus on folks who have mental health crisis, and 16 beds for people who need to detox, with a sort of shared lobby space. So 2 wings, but with separate services that will allow for Medicaid funding to pay for those who are in need. The other limitation is that all facilities are regional. We are part of a 5-county region, and that means even though the triage facility that we're envisioning will be sited here in Whatcom County, it will be shared by the region. And that way, because of that, we anticipate that even if we go as big as we can go, it is a facility that is likely to remain full. Whatcom County is close to having the funds necessary for capital expenditures. I think we're about $1.5 million short right now, but we're closing in on the money we need to break ground. And if everything goes right, we should be in a position to break ground at the end of 2017 or the beginning of 2018, which is really good news. But in the background of all of this is the changing healthcare landscape in the political world, both on a federal level and at a state level, and that would impact potentially the monies that we need for operating costs. If everything were to remain as it is today, we know that we could open a facility and staff it and provide quality services to people in need. But as things change, we have at least a question mark as to what sort of monies might be available for us, but we're remaining optimistic that this common sense proposal to provide services in the community in a small facility makes sense. It makes fiscal sense, and hopefully common sense and reason will prevail, and we'll continue to have the monies that we need to take care of people in our community. The second committee is the one that I'm attached to formally, which is we're calling the Law and Justice Subcommittee. And here we're looking at how things are working in our courts and in our jail currently, and looking at ways to perhaps improve systems. We have already done lots of exciting things, including working with the sheriff to get the necessary funding for an expanded program of electronic home monitoring, including looking at new hardware that's available to help monitor people in the community, so hopefully they can be safely out of the jail and in the community. We are looking at things as small as speeding up applications for our current drug court program, funding for a social worker inside of the public defender's office, and helping the probation department to look at ways to focus their resources most effectively. But the part that has us most excited is looking forward to really reducing the population inside of the jail. 1/3 of the population on any given day of the offenders or of people inside of the jail are sitting there waiting for their trial date. They're there pre-trial. That means they're presumed innocent, and that means that they've been convicted of nothing and they're just sitting in jail waiting for their trial date. And when we look at this in a larger way, our court rules in Washington tell us that everyone should be released pre-trial and without bail, except if there is a question as to whether or not they are going to return for their trial date, or if they perhaps have behaviors that can't be, they might commit additional crimes while they're out waiting for their trial date. In those situations, the court rules allow the judges to set bail or to set conditions for their release. So when we're looking at this, we're looking at a real opportunity to look at this 1/3 of the current jail population and look at ways to perhaps release them in ways that would make sure that they return for their trial dates and hopefully manage their behaviors in a safe way while they're waiting for their case to be heard. And there are great models that are happening around the country, in the federal courts, in state courts, and even in the state of Washington. And we're looking at a two-part, it looks like I'm almost closing in on my time, so I'm going to speed ahead here. We're looking at a two-part proposal that would focus on an evidence-based risk assessment to help judges figure out who can safely and properly be released, and also at a pretrial supervision unit that would help monitor folks who have been released awaiting their trial. And if you look at the dollars and cents in this, I think that in Yakima, they found it costs $89 a day to hold people in custody pretrial and $8 a day to release people and supervise them in the community. So dollars and cents this is a logical choice for us. Before I finish, I also do want to highlight some words that came to us today from Darlene Peterson, who's the court administrator for the city of Bellingham. And you may know that all 7 of the small cities in our community have their own courts, including the city of Bellingham. Some of you have been following in the newspaper that because of jail capacity issues, Bellingham and the other small towns have been told that they can't book their people following arrest, and so the articles in the paper have been focusing on shipping inmates over to Yakima. While that's true, it has also been the catalyst for the city of Bellingham to work hard at reducing their jail population, and I'd like to give them a gold star for that. Here's what Darlene writes to me this morning. She says, the Whatcom County jail costs have gone up from a daily fee of $98 a day last year to $108 this year. To be on the Whatcom County out-of-custody work crew is now $66. To be on their electronic home monitoring is $53 per day, and they now charge a $100 booking fee. Electronic monitoring with the city is $14.50 per day, and it is the same price if more sophisticated hardware called the Scram device is needed. The city also supplements indigent defendants if they need financial assistance. Last year, the city defendants completed 3,099 days of electronic monitoring at a cost to the city of $14,757.21. Had these days been served in the Whatcom County Jail at last year's cost of $98 per day, it would have come to $303,016, and this is without booking fees. Darlene goes on to write, this is a huge win for the county and the city in that 3,099 days were not served in the local jail, but allowed defendants to work, attend school, keep their homes, serve their time without the need for incarceration. So the city has eligibility screening tools, and they're just moving ahead and have in every way demonstrated a commitment to reducing and preventing incarceration. So that's some good news I get to share with you today. I'll just tell you that our 3rd committee is working on behavioral health issues. This is under the leadership of Ann Deacon. And the most exciting project that they're working on is a pilot project that will have our police and mental health workers collaborating together to focus resources on a very select population in our community. Historically and before the Affordable Care Act, about 5% of the population has used 50% of the resources. And that includes everything from EMS and the jail to the hospital and law enforcement. So by focusing resources on this particular population, having the collaboration of the mental health crew as well as law enforcement, we're hoping to further reduce and prevent incarceration. I seriously could talk all day about this and would be happy to, but I think that my time is up today, so. I'm sorry, I do have one more thing to say though. I was promised that I could cross-promote an event that's happening with the League of Women Voters, and this is going to happen on Saturday, April 15th at the Heiner Theater. I'm going to have these to distribute later that tell more about it, but the focus is going to be on therapeutic courts that are being used in other communities, as well as programs that help safely reduce people pre-trial. It's going to be a really exciting conversation, and I hope you can join us. Thank you.
Thank you, Jill. And so now we'll hear from Dr. Bob Crittenden about some of the changes in healthcare happening at the state level and how that might impact these selected populations we've been talking about.
Great. Thank you very much. I had a cold yesterday, and you can hear it. I haven't gotten over it entirely. So please bear with me. I'm going to talk about 2 things, or maybe more than 2, but one is a little bit about this whole ACA kerfluffle going on back in D.C. And I just want to talk about it because I think it really right now it undergirds a lot of our behavioral health expansions and changes we're doing. Taking it away will make it a lot more difficult for us to do the things we're going to do in the future. What the ACA did was actually helped us cover people who are mentally ill, cover people who have substance abuse, so they get the treatment they need. And right now, 27,000 people in Whatcom County alone have one of the have either Medicaid or Apple Health from the exchange, and as well as an insurance plan from the exchange. So it's really impacting the whole state. We have about 750,000 people altogether. One of the things they say about it, and you'll hear more about it next month, but they say that our system is broken, that it's terrible. And I'll just say that what we've done here, we've implemented the ACA in a way it was meant to be implemented. Our people are covered. Our costs are going down, actually, not up. They claim that it's all getting worse, and in fact, everything we can look at is getting better. We have better coordination of care. We have an ability to cover people and treat people who need it. And it's, I think it is disingenuous of the debate in D.C. to say that it doesn't work. And just a minor little detail, if you look at, and I'll say that the ACA doesn't work everywhere. And where it doesn't work is where they did not implement it. And the difference, the difference between the inflation rates for the small business, or a small part of the individual market, is a full 10% difference. In those states where they did not do it, the inflation rate is going higher. In our state, it is coming down. It's gone from 18 down to 6% over the last, since before and after the ACA, as far as the individual rate increases. And that's a 3-year average in both time. So the point is, I think it's really been very successful for us. And it's really benefited patients in a way that's been very helpful as well. So he'll tell you more about it, but I also want you to know the governor is fighting like crazy. In fact, we have a meeting this afternoon with both the AG and Senator Murray to kind of, I'll say, strategize around it. He's putting a lot of his effort into it. He's gone to a lot of different events. And I think it's really important for you and everybody else to let our elected officials, particularly the ones back in D.C., know that this is an important thing. And I think your representative has been very good on the issue, but we have a few other in the state that haven't been so good. So I just want to say that because I think it really is applicable to what we're doing with mental health and substance abuse treatment. I just want to talk about a couple of patients that I've had. These are actually patients of mine. One was, I'll call him David, who was an Evergreen student, got a little confused in his second year, kind of dropped out a little bit, wasn't able to focus very well, went back to school, finally ended up graduating, went on, wanted to be a photographer, tried doing that for a while, and then occasionally worked in coffee shops. Didn't do very well, actually. He continued to have these episodes of confusion and doing kind of crazy things. Finally, he ended up having a big break and ended up getting diagnosed with schizophrenia. It took him about 5 years, but he got there. Another one is a good friend of mine, actually named Randy, and he was working in the white collar sort of a position, had actually a full psychotic break, but he had a very supportive family and treatment, and he was treated very well. He went back to work after about 3 months. He finished up his job. He was there. He worked about another 4 years. Went on, and ended up being the deputy director of a statewide association and worked until he was 70 and retired. He had occasional episodes. And the reason I bring these two people up is that one got treatment early and one didn't. And we think of these things as, well, somebody's psychotic, so we treat them. But in fact, they're chronic illnesses. Same with substance abuse. They come in, they start, and they keep getting worse. And particularly in psychosis, you start off and you get worse over time, till finally you get eligibility for treatment. In our system, up before this time, if you didn't have a full-blown psychosis, you did not get treatment unless you had other insurance. Medicaid didn't cover it very well, and so we never prevented anything. And so what happened, what the Affordable Care Act allows us to do now is that people, if they are now can be enrolled, like David, for instance, could have been enrolled in Medicaid when he was in college or after college. He could have gotten treatment early on, and he could have maybe been more like a Randy instead of like what happened to him. And so I think it's really important for us to understand that this is a spectrum, that we do a very poor job of prevention, and we need to think about that. The reason I bring it up also is that we know that 40% of the people who have mental illness diagnosed actually get any treatment. And for substance abuse, only 20% get any treatment. And the question is, why is that? Well, the issue is, as far as we can tell, is that they're diagnosed, but they're not part of our state mental health system. And our Medicaid system hasn't really done a very good job of treating them. And also, a lot of times, they aren't eligible for Medicaid, because to be eligible for Medicaid before the ACA, you had to be a pregnant woman, aged, blind, or disabled, or a child, and that was it. So here you had people like David, who never had any eligibility, and now he's eligible and we can do it. So what we're doing, which is really the question I think for today, is what are we doing with the mental health system, at least at the state level? And I'll say it's not without controversy, but I think it actually is the right thing to do. What we're doing is that we are looking to integrate our financing of healthcare so that David, when he has his first illness, can get treatment, and that same treatment, he can get the full spectrum of treatment until, if he does get worse or doesn't get worse. But we focus on making sure he gets that treatment early and gets it appropriately. So what we want to do is have one insurer that covers the full range from beginning to end, and the full spectrum. So we're integrating the financing. We also decide that we are not able to treat people appropriately, and very apropos to the diversion issue, is that we did a bunch of work this last fall where we had a lot of, I'll say, consultants working with us, and we looked at how our whole mental health system was structured, and we also looked at how our diversion, we had a special study looking at diversion, and what we came up with on the mental health system was that we were way too centric to big institutions. We have this western state and eastern state. They're huge. They're, 90, 80, 90, 100 miles away from, more than that, probably 100, 120 miles away from you. As people go in, they stay in for an average of 9 months. And so somebody becomes mentally ill, they get shipped off to Western, they never get out for 9 months. They've lost their home, they've lost their family. Oftentimes they have lost all their connection back home, and then we send them back home and expect them to pick up where they were. And we know in healthcare, what we always do is we plan things ahead of time nowadays, and we plan discharge right away, and we plan to get people out into their home. How do you put people in the most appropriate level of treatment? For instance, you don't just keep somebody in ICU, you take them from the ICU down to the regular step down, and then you get them into the community, maybe into a nursing home or a respite care, and then you get them home. So why we don't do that in mental health, I'm not sure. So we looked at that as well. So we felt that we needed to move more that direction. So we actually put a lot of money into the budget, and I'll say we don't have it yet, but we are hoping to get it. And we're looking at low and no, for instance, we're developing one small civil commitment bed institution of about 16 beds. And the magic 16 that we use, there's a story behind that. We can't charge Medicaid for anything over 16. It's a federal law. So a 16-bed unit in every region. So we have 10 regions. We'd have 16 beds in each region. We also wanted to put in low and no barrier case managed housing, street outreach, crisis walk-in centers. What we found with diversion was the biggest barrier to getting diversion programs working in a lot of communities was actually the places to put people. There are very few places to place somebody who has substance abuse, detox units, they call them, and other things. So we putting money into that. So we're putting about initially about 300. I think it's down to 200 now in the budget discussions, but they're stretching it out over a longer time with the idea of taking our civil commitment beds and ramping them down at Western State and ramping up the community-based facilities with the idea that we can locally manage people, help them, keep them in the institution when they need to be there, but get them out, get them into the community as fast as we can. So we are doing that, and we're asking for that money. We'll see whether we get it or not, but there's a good chance we will. One of the issues that came up that I was asked to at least touch bases on was the SWIFT Center, I believe it's called, at Old Northern State is going away, and that's a discussion that preceded me and I didn't know about until about a month ago. But talking to your BHO up here, they are in the process of developing about 32 new beds in the region. I think the one facility you're talking about here is one of those facilities, so that we have at least 16 beds for substance use up in this area, and I think another 16 further south in the region. So I think there are ways to resolve or to solve that problem. One of the things that in this integration effort we've been doing is that actually the rates were a problem for substance use, and now I think we're doing a lot better with that, given the ability to put things together as far as financing. It turns out that if you actually manage people at the appropriate level, you can do it a lot less expensively instead of putting people into high-intensity units. And so we think we're going to be better off financially if we do that. The interesting thing, too, is that the Davids of the world die about 25 years younger than the Randys of the world, which is an important thing. And they don't die of mental illness. They die of diabetes, hypertension, cardiovascular disease, whatever. And the reason they do is they don't get care. So one of the efforts we're having in this whole thing, a lot of our resources are going to develop integrated behavioral health and medical services so that we would have co-located mental health and medical care in the same place, either in a behavioral health facility or in a medical facility. And in my last clinic I ran at Harborview, where I practiced in the last 16 years before joining the governor's office, we did that. We had a psychiatrist part-time, we had 2 mental health professionals, a social worker, and we were able to treat a very high intensity, high level of dysfunction crowd there that we were able to do a very good job with by combining the two, and we were able to treat them well medically too. And I think we can do that throughout the state. So that's what we're up to right now. One of the issues that comes up is what's the role of the county in all this? And first off, we really believe the county has to be very engaged. We think it's much more important to have them engaged and involved because they're the ones locally. And so what we've been talking to some of the different counties as well as some of the BHOs about what that role could be. And we're trying to think of, we're very flexible about it. We like the counties to be involved. Some counties, interestingly, don't want to be involved, the ones we've talked to. A lot of them want to be involved, and it ranges from oversight committees to other things. But we expect and hope that the county is involved. And also, one of the things in this whole integration is that we do not take over any of your local money or funds or anything like that. We are actually just trying to manage the Medicaid funds and make sure they integrate well with the local services you've heard a lot about here before. So I'll leave it at that and turn it over to questions, Ann. Thank you.
So let me ask a couple questions and then turn it over to all of you. One question I have for you, Dr. Bob, is our county and other counties are investing in the construction of facilities that provide acute behavioral health services on a voluntary basis. So I know you were talking about moving a lot of the involuntary beds from Western State out into the communities, which we realize is critical for us as well. But we're also wanting to prevent people from having to go into crisis, go into the hospitals, certainly trying to prevent them from going into our jails and interface with our law enforcement a lot. And so we are here expanding our triage facility for voluntary services, and it is a county facility. We're putting in local dollars for this investment. And so one of the questions we have, and certainly in discussions with other counties who are doing the same thing, have this question, which is, as managed care organizations, most of them commercial health plans, take over this administration of the Medicaid services for primary care and behavioral health, what assurances do counties have that these investments will thrive because the managed care organizations will indeed purchase these services?
Now, I think that if you look at the services that are available, there are very few of them available. And so I think that they will, our experience so far and our encouragement of the MCOs, particularly in Southwest Washington where this has gone on, is to build on the local services and integrate with it. And I think the experience down there has been pretty good about them supporting and getting people into those services. So I don't, is it going to be a problem? I think in the short run, it probably won't be a problem at all, just because you're going to have, you have a shortage of services and people are going to have to use the ones that are there. Over time, there may be some settling out as to who owns and who buys and who sells things. I don't think we can control that at this point. But I think in the short run, I don't see any problem. In fact, I think quite the opposite. One of the things we're doing is putting our own state money into a lot of services like that. The idea that they will be used. And we need the capacity.
Great. And I understand that I forgot to interpret, and that's my bad. So we talk about BHOs a lot. That is actually stands for Behavioral Health Organization. It is a regional entity that administers the Medicaid services for both mental health services as well as substance use disorder services. So that. I didn't know he was talking a different language until somebody told me, so sorry. And then, Jill, I have a question for you. So you've talked about some of the great efforts underway for the new programs that we're developing in the task force. What is the task force doing in terms of looking at current programs in operation?
Well, that's a big question. And that is part of our mission, is to examine, for instance, what we're doing to make sure that best practices are being used. I can think of an example being when you are convicted of a crime involving domestic violence, you will be court-ordered to attend get a domestic violence evaluation and attend counseling services. Well, these are all state-certified programs, but are they evidentiary? Do we know that they work? Do we know that they employ best practices? We have not taken a look at this. And so that is on the slate, and what's going to come up in the near future is using the task force's resources to look at local programs, to examine them for best practices, and where they need improvement, to recommend those improvements.
Great, thank you. And again, for you, Dr. Bob, and I'll preface this with some interpretation. So the behavioral health organization that I spoke about is one that currently has a governing board made up of county elected officials. So the 5 counties in our region, which is Snohomish, Skagit, Whatcom Island, and San Juan, all have elected officials that sit on that governing board. And they, of course, have immediate and direct influence over how services are provided and what services are provided. And so counties have a really significant voice in addressing local needs and also the ability to influence the programs and services that we offer. In 2020, the move at the state is to move toward managed care organizations, commercial health plans, most of them, to administer these services, and the counties would no longer have these behavioral health organizations doing that work, that it would move to these private organizations. And you alluded to this obviously earlier, but I wanted to just make sure we emphasized it today to help hopefully alleviate some angst about that. How do counties really have an ongoing influence in how these services are provided, what services are provided, so that what we know is that inadequate or ineffective treatment leads to costs that the counties bear, either jails or EMS, et cetera.
So there are a couple ways that I think will be addressed effectively. And one is just having, right now in Southwest, we have this advisory group made up of the county, the MCOs and other people. The idea there is that the county has a direct influence. The second thing that we're doing is we're setting up in our contracts with them performance measures, and performance measures will include things like, they're going to jail, whether they're using services inappropriately, et cetera. And so that, in fact, they will be paid more or be paid less if they don't do those things. So there's a strong motivation on their part to do that as well. And so there's a motivation for them to actually work very closely with the county, because they are going to depend on services that you control for a lot of the work they do. So I think there's a need for both sides to work close together. The question whether I like the idea of private, for-profit organizations or not is I don't know. I don't really have a strong. I really don't. I'm neutral. I think there's some good points and bad points. I think the issue really, though, is whether they are motivated by, I'll say, working together. And I'll tell you that where they will save money is where they treat people appropriately. Everybody says they're concerned about them, but they will make money if they actually do the right things and invest the right way, because the cost to them of mental health is not in the mental health costs, but is in the medical costs. And if they don't treat people with mental health well, they'll pay a lot of money for doing that. So I think there's a huge motivation that they have to do that. And we're looking at a way of doing, actually, we call it a shared savings program, where in fact, if they meet the goals and save money, that money, if it's reinvested upstream, that in fact, upstream being in mental health and other places, that they would in fact be able to take some of the savings and send it off to corporate, I guess. But the point is they'll have a motivation to do well and do good both.
And one last question for me. Speaking of prevention, and that's the other half of the reduction, right, in our incarceration task force, Jill. What kinds of discussions have occurred in terms of that role? So preventing incarceration.
Well, I would just have to channel you because the mantra from Ann has been about the continuum of care that's necessary. It is not enough just to have someone make a quick pit stop at the triage center and call it good, but rather to make sure that we have appropriate services in the community to treat people beyond the immediate crisis. And to the extent that we can provide those services, we are going to see prevention. And when people are released from jail, to make sure that they have adequate services waiting for them when they re-enter the community, to hopefully allow them to stabilize their lives in a way that won't have them returning to the jails. So Ann Deacon has reminded us at every turn that the continuum of care is our best bet towards reducing and preventing incarceration. Does that answer the question?
I think you did good.
Did I
That
do good?
was a softball
You barely
throw,
saw
wasn't
her
it?
hand on my back. No, but I have a question.
We
So,
don't
but you can help me
have
with
rules
my.
against that. You go right ahead.
You can help me. You can help me with my question. Isn't it 118 beds at Northern State Hospital that we're going to lose, or is it
Well,
140?
There's 141 beds at the old Northern State grounds, which is treatment for substance use disorders. And I will say that at this point in time, the Pioneer Human Services is losing their lease for a number of reasons. And so there is planning underway in our 5-county region to make sure that we have beds in place. And so in our community, as Dr. Bob referred to, we have a 16-bed inpatient substance use disorder treatment facility opening up sometime in the next couple months. We have one planned in Skagit County and one planned in Snohomish County. So we are working actively to address that need.
But my question for Dr. Bob is, we're working hard on all of this. Is this anticipated to take care of those beds that are currently filled at Northern State Hospital when we lose them? I mean,
Well,
are we
you
going?
talking about the 141 versus the 30?
Correct.
Yeah, well, it turns out that in your region, only about 30 to 40. Yeah.
So we're good.
Well, you're close.
It was a statewide facility, so people from all over the state were sent to this facility, similar to a Western State or an Eastern State hospital for mental health, that people all over the state use that facility. Jane, shall I turn it over to you?
Yes, thank you. Thank you, Anne, for doing such a great job. Anne knows so much more about this than I do. She made a great moderator. So now we're going to open it up for questions for you.
Thank you both for your presentation. Jill, I have a question for you.
Yes,
I know
sir.
that you had said that the task force was not directly charged with anything relating to the size of the jail, but of course they're related. I'm curious to know your opinion. To what degree do you think the recommendations from the task force should inform the size of the new jail?
Actually, there are people who know the answer to that question. For instance, I've been in touch with the people who were coordinating with at the Vera Institute, and there are people who, this is part of a science, where you look at the demographics of the community. We know that we're an aging population, meaning we're less likely to commit crimes. We have thankfully had a reduction in our juvenile offender population by, I think, about 90%. And that means that there'll be fewer people feeding from the juvenile system into the adult offender system. Those are important statistics. If we are successful, as I hope that we will be, with the task force work, that will help reduce the need for jail space. And there are people through the Vera Institute who could help our community to answer that question then of what that number should look like, what size jail we should be planning for. And I'm personally, Jill, citizen, going to urge the county council to avail themselves of those resources, whether through Vera or elsewhere, to look at this as an exercise of something more than just throwing a dart at the board, but rather to come up with a number that's appropriate for our community, both for the moment and also for appropriate long-term planning.
My name's Amy Glasser, and my theory is that if we get housing for the homeless and we pay for it, that we'll be able to avoid a ton of incarceration because the police could then just take somebody home instead of to jail when they're acting out in the community. So I'm just wondering whether or not monies for these kind of programs, even though I know there's different pots of money for housing, if this kind of money can also be going to housing programs in order to avoid incarceration.
The other piece of my speech that I couldn't get to had to do with the systemic problems that we're looking at in our community that are frustrating our efforts. And one piece is housing. Most of you in the room know that the housing crisis in Bellingham is real. The statistic as of this morning, I think, is that we have a 0.2% vacancy rate, and that, I was telling Dr. Bob, that means he and I could probably rent an apartment, but folks whose lives are not as stable, who's don't have great credit, are going to have a heck of a time finding housing. Most communities that have been successful around the country in reducing and preventing incarceration have made their mantra housing first. And when you have housing, and you put that at the head of the list of services, then once you get people sheltered, you can then provide services. This is being used every place from Salt Lake City to, I think, New Orleans and places in between successfully. And clearly, we need to do something to address this crisis in our community if we're going to be successful with the long-term projects.
It's for very vulnerable populations, not just having the housing, which is very important and hard to get, and we are trying to put as much money as we can in our capital budget into the housing part, but we also have supportive housing, which means supportive services, and we do have the ability to support that through Medicaid, and so for our what do you call it, our demonstration waiver, 1115, we have $1.5 billion right now from the federal government, previous administration, by the way, and we're going to use that for part of that for this.
A general question. Does the system distinguish mental illness and traumatic brain injury etiologies of aberrant behaviors?
If somebody's diagnosed with certain kinds of problems, is that a cough? Oh, thank you. This is actually just candy, but I like it now.
It's chocolate, but we didn't want to tell you.
You know, if somebody has certain behaviors, whether they have a traumatic brain cause for it, it still is a behavior problem. So oftentimes you do make those distinctions, but if somebody is acting in a certain way, it does, you do tend to treat them for that as well as the traumatic brain. The problem with traumatic brain injuries, it's an organic problem, which means it's very difficult to change the underlying problem, but you can change the behavior.
Hi, I'm Rod Burton. This question might not be appropriate for this panel, but there was some reference to things, so maybe you can answer it. Responding to Ann Deacon's notes here about behavioral health treatment alone is not necessarily effective in changing criminal thinking and behavior, I'm wondering what programs are in place to change criminal thinking and behavior.
There are actually evidence-based programs out there that, in fact, do target that. And so some of the ones that do are employed in a number of these programs. Moral recognition therapy, for instance, is a popular one. It's used in some of our specialty courts. The juvenile program has about 2 or 3 different evidence-based programs that address that. That gang prevention programs that we have targeted for certain areas of our community are evidence-based to address that thinking and behavior. And so we really do understand that, in fact, we have even noticed that some people who are significantly challenged when they are psychotic, as they get treatment for their mental illness, they stabilize. Sometimes they are more effective with their criminal behavior. And so we actually then have a responsibility to treat that as well. So, and that's, most people don't know that, but when you work in a prison that has nothing but people with serious mental illness, you start to learn that some people can become very dangerous and predatory when they're organized in their thinking. And so it's very important for us to ensure that we recognize all the issues that need to be addressed.
I'm Pat Britton, and I guess my question is, if you don't prosecute as many wrongdoers, you would have less of a prison population. Are we prosecuting too much? Is there a part of the task force that says, wait a second, maybe we shouldn't be prosecuting low-level offenders? Is there any work on that? Or maybe that's not an issue.
Well, the sheriff has asked, for instance, the city of Bellingham to review their statutes to look at things that can be decriminalized, like failure to have garbage service and things of that sort. And so I believe that the city has undergone a process of reviewing their statutes to look at what can and should be decriminalized, laying on the sidewalk and urinating outside and so forth, as well as garbage service, and to look at what can be decriminalized. And then the pilot project that Ann is working on, there are models for this in the state of Washington. They carry all sorts of different acronyms about looking at a population that's using all of these resources. And what can you do if you then have police work with mental health professionals so that they can recognize what is criminal behavior and what is a product of mental illness, in the hopes that people can be appropriately treated before they're ever arrested, before they ever walk in the doorway of the jail. And so the answer to your question is yes. We're looking at this systemically to look at ways in which we can, before people ever enter the system. And part of that is what really needs to be prosecuted is a question we're asking.
Thank you. My name's Sherry Lambert, and I have a question, and maybe it's more for Ann, I don't know. But is anything being addressed at the young levels, like kids suffering with ACEs or adverse childhood experiences? And those children are the ones that are going to grow up to be frequent flyers in the system here.
The answer is yes, a lot. We're very proud of significant programs we have. We call that prevention, early intervention services, and we're doing quite a bit. We're very well versed in ACEs. We've had some of the big wigs up here training many of our community professionals. At this point, those really early interventions have not been included in the incarceration task force. It has certainly been discussed about how broad our scope is. At this point, the steering committee has decided, let us narrow our focus to the task at hand more immediately and continue to stay abreast of what is happening with the prevention and early intervention efforts. But yes, quite a bit is happening, and it's pretty exciting, and that's a whole nother program.
I understand, I hope it's not a misunderstanding, that Peace Health has recently decided to eliminate the social workers certainly in the emergency room, if not throughout the hospital. If that's correct, do you expect that, particularly in the emergency room, to have an impact on incarceration rates, given the services that those social workers would provide?
I would say, my instincts say yes. And one of the places that the task force is looking, and when Ann said what's on tap, is the emergency room, which is where a lot of things happen that later do impact incarceration rates. For instance, the emergency room is where people are brought who are going to be evaluated for involuntary mental health care in our community. And when they are not happy about being there, act out physically, either physically assaultive or spitting, the next step is the jail, where they're charged with a felony and wind up sitting in our jail awaiting trial on an assault in the third degree, a felony charge. It doesn't happen a little bit, it happens a lot. And so you make a shift in the emergency room and you take out talented mental health professionals that will absolutely affect then what happens in the rest of the systems.
The bed mathematics, 16 beds limitation for Medicare, Medicaid. And I got confused as to whether that's just facility, but you could have as many facilities as are funded both publicly and privately, whether it's county, region. I just got blurred on that point.
Yeah, it is a facility size, and it was basically put in place because when they first did Medicaid, when they applied, I'll say, coverage for services in Medicaid, they didn't want to pay for the big state hospitals. So they had an arbitrary number of 16. They figured all the ones in the country were bigger than 16. That way they didn't have to pay for Western State or places like that. So it's a historical figment. Probably would be 23 or 25. It would be more efficient. The number of people in the civil commitments is in the area of, in Western State, is the area of about 200-ish who are not developmentally disabled, not elderly, and so we call kind of the run-of-the-mill group. And so if you have 16 of these, 16 beds, and you have in 10 regions, you have 160 beds at the minimum for civil commitments. So we're pretty close to the number that way. And if we do, some prevention, it should fit pretty well. So in other words, you can build all you want, but you don't want to build more than you can use.
This is a question for Dr. Bob. What would induce a county to decide that it doesn't want to play and doesn't want to be a part of the solution?
I mean, as far as working with the MCOs or the managed care organizations,
Yes.
I think I think there's a region right now who's, starting to move that direction, probably who won't do much playing. They will have, but it is in everybody's benefit for the county to be a part of it. I mean, the county would, I would suspect, would want to have influence over what's being put together and what kind of services are available, because they do interact very much with the jails and with other things. And counties have their own, funding. They have their own services. And so I think there's a lot of reasons why they'd want to be involved. Are you asking whether or not they would just take a hike and not do it?
Yeah, didn't you mention that there were several counties not participating? That was what I had heard.
Oh yeah, there's one region right now where looks like the counties are just going to be very passive. They don't want any risk at all, and this is in the north central region. And I don't know exactly what's going to come up, but I think it's unfortunate. I think the counties should be engaged.
I'd like to add something to your question about the number of beds. We actually, as we were looking at our recommendation for the county council about the size of the triage facility, we actually, a needs assessment was undertaken in the community, and we know that we, in this region, will well fill 2 16-bed units at our newly envisioned triage facility, and that we will have more need than that. But that's as big as we can go.
The question I have is, what is being done to assist or educate teachers in our schools in the early intervention, such as the elementary all the way through the high school?
The county alone, in terms of our local sales tax that is focused on behavioral health services, we invest over $1 million every year in all 7 of our school districts. And we work with each school district specifically to identify their particular needs, and we design programs in conjunction with their efforts to provide those services. So that is elementary school all the way through high school, including alternative schools. So significant efforts in that regard.
So I have a question about, and you mentioned that often people who end up in the jail do suffer from mental illness and substance abuse disorders. And sometimes there's also criminogenic factors that we can't necessarily help by solving the mental illness and the substance abuse. But if we did have an ideal system that did help our mentally ill and our substance abuse disordered people, do we have an idea of how that could reduce our local jail population, what that magnitude is, that specific population?
So there's varying levels of severity. And so when we were looking at just those people, for instance, that we could divert from jail who had very serious mental illness and misdemeanors, we came up with somewhere between 16 and 20 in a given month. So it wasn't a lot. There are, I don't have a number for your particular question, but I would say that at this point in time, our current jail has no space for programming. So we don't have any ability to address both those issues. We barely address the mental health and behavior and substance use disorder needs. We are bringing in another full-time position to address the substance use disorder to work with our jail behavioral health program. But with that said, most of it is geared towards stabilization, connecting to services, and ensuring that there's a smooth handoff back to the community. But without space in a jail to actually do programming, we do not have the ability currently to offer those services. And I don't have the math for your other question, but it's something we should look at.
I think we learned a lot today. I want to thank our presenters